Today's piece is the Lunchtime Lecture, sponsored by Deltex Medical. It's Perioperative Haemodynamic Management with our very own Professor Monty Mythen. Have a listen.
Top Med Talk. Right, welcome folks. I've said hi already. Monty Mythen. I'm one of the Directors of Evidence-Based Perioperative Medicine. This is a lunchtime sponsored session, sponsored by Deltex Medical, long-term supporters, original supporters of evidence-based perioperative medicine, who have devices to measure cardiac output, in particular the esophageal Doppler device that I worked on a prototype nearly 30 years ago now, doing some of the original perioperative goal-directed fluid management studies, which I'll refer to in passing. I just want to point out at the top of the slide here, apart from the EBPOM logo, I hope you can see that okay, you'll see a number of slides appear the Morpheus Consortium. Now, the Morpheus Consortium is a collaboration. At the moment, the signed-up partners are UCL, Duke University in North Carolina, and Southampton, but that group will broaden over time. It's a group that's trying to share best practice around the world, what we believe to be current best practice, recognising there are different economies around the world. And the other thing that's at the top there is Top Med Talk that I've referred to, and that is this internet radio station. This is a slide from earlier this year when we were at the Royal College of Anaesthetists meeting. It's an internet radio station such that we've been live streaming this event to the world, and then we podcast them afterwards. So if you want to go home and say, actually, that's not what Professor Miles said, he actually said this, listen to him, you can play it to your colleagues or point them at the podcasts. And the podcasts range from 2 minutes, where they're little snippets, Journal Club Express, for example, up to yesterday we did an hour, which was a preparation for this meeting. It's all completely free, real free, not sort of free, real free. So if you go to the Top Med Talk website, at the bottom, if you don't understand podcasting very well, which I didn't about 18 months ago, there's instructions there about how to get into podcasting. If you don't understand podcatchers, if you're an Apple iPhone user, for example, there are other phones available, you'll find that little logo there is on your phone somewhere. And if you press on it, you can get access to all the podcasts in the world. And if you like what you're listening to, you can subscribe, and the podcast will be you'll be alerted to the podcast availability. We put out a minimum of one a day. We've done, since January this year, we've done about 180 podcasts. We are on target this year. Our target originally for this year was to have this is our first year of a hard launch, was to have 10,000 downloads in the year. We're now doing that a month, and we're on target for 100,000 downloads or more this year. And we've got listeners in 90 countries around the world, so from Australia to Zimbabwe. So it's fantastic reach, the whole thing. So please do engage. And then with a combination of things like the Slido technology or social media, we're getting huge conversations starting to happen about these various different issues around the world, which I think is great. So if you look at the team, the Top Med Talk team doing their recordings in the trade exhibition, or they'll be tucked away in various different corners, if you go and talk to them or pick up the material, they'll explain to you how it all works. And if you're running events or you want to come to our studio in West London and get involved, please just contact us. We've got a beautiful studio at 1010 Great West Road in what used to be a hospital that is now a law firm owned by Martin Howe and Company. Martin is an attorney, a civil rights lawyer who opened the Grenfell inquiry, which some of you in the UK will know about. He's a great believer in free speech, and part of that, it's a long story, is he has a beautiful radio station in his building where his firm works out of, which used to be a hospital. You could only make that sort of thing up, couldn't you? Anyway. So, my remit is to talk about hemodynamic monitoring, hemodynamic management, and what's new. So here's my summary slide for those of you who want to leave now or go back to sleep, or you found yourself in the wrong room. We're worrying about blood pressure again. We probably thought we always worried about blood pressure, but we've had heightened concerns about appropriate levels of blood pressure. And perhaps the numbers to worry about, pragmatically, are a mean of 65 and a systolic of 90. And there's been some greater clarity about that, and there are some in-press international consensus recommendations that those are probably the best numbers to work with at the moment for non-cardiac surgery. Cardiac surgery seems to be a little bit different. Quite a lot of discussions about the use of vasoactive agents perioperatively, and perhaps that the infusion of norepinephrine in particular, which is both alpha and beta in its effect, maybe a more sensible way of approaching it than having a stick and giving pushes of phenylephrine or metaraminol, which in major surgery seems to be ubiquitous. So if you look at the big trials, it seems as though everyone gets a hit of squeeze during a big case, even though we all say that we're not doing it. None of us do that, do we? It's all the others. That's the problem. One of the big discussions when we come on to talking about the evidence about fixing pressure is the fact that it probably, on balance, remains the fact that you should worry about the volume before you fix the pressure. You can fix the pressure as a rescue measure if you have reduced blood volume, but you will be robbing Peter to pay Paul, on balance. I'm going to touch on haemodynamic monitoring and management, but I'm going to start with thirst and the relationship between thirst and volume status, because this has become a new interest of our group. So here's a review article published recently in the journal Perioperative Medicine. Now, interesting, when surveyed in the UK, the commonest post-operative complaint from patients now is thirst. It's gone, so nausea, vomiting, and pain have dropped down the list. Thirst seems to have gone to number one. And there's lots of reasons why patients may feel thirsty post-operatively, but in part, it may be that we render them or leave them relatively hyperosmolar. So even if their volume status has increased, they are sensing thirst because our thirst sensors are osmol sensitive. So a recent survey done by Geoff Lacey, colleague, the majority of patients in our major post-surgical intensive care unit are hyperosmolar. So one might presume may be thirsty. Now here's a diagram. This came out of a recent consensus meeting. It's a 9-panel plot where you've got volume status up the side and you've got thirst along the top. So the sweet spot in the middle is where we hope to be at the moment, i.e. we're isoosmolar and isovolemic. And you can deviate in all the different directions into those 8 other plots. But post-operatively, one of the common places, if you haven't left people dry, which is more obvious, is to have a patient who is now volume overloaded, or the new sweet spot according to Paul Miles's study, i.e. plus 2 litres. So your total body water is now up, but your total body salt is now up as well. So if you have used a salty solution, you may be hypervolemic and hypernatremic, therefore your osmols are up, therefore you will feel thirsty. And what you probably have to give that patient is free water. So a more hypoosmolar solution, like 5% dextrose, like dextrosaline, like what some of us in the room were brought up to do with post-operative patients, because they need that free water to be able to pee. They can't get the salt out unless you've got the water to allow it to transport out of the kidney. And that's very basic human physiology that a lot of us seem to have forgotten about. So here's a very simple study that may underline that point, 30 healthy volunteers, published recently in the British Journal of Anaesthesia. It's not a competition, these journals. This one just happens to be number one in the world. Okay? I don't want to get drawn into these pathetic discussions about who's best, but this one's number one. Okay? And what we've done here, a group led by Finton Hughes, Hugh Montgomery, etc., we've taken some healthy volunteers and we've electively dehydrated them. So we've got to put this in context. These are young, fit, healthy people. We've starved them overnight and then we've given them diuretics to dehydrate them. And then we've randomized them. It's a crossover trial, so they act as their own control. In one limb, they get the NICE recommended maintenance fluid regimen. So we get the piece of paper out, we work out how much we think they need, and we put them on an infusion. In the other group, we give them a bag of dextrosaline connected to what looks like a PCA pump. So it's patient-controlled hydration, and they can hit the button until they don't feel thirsty anymore. And in healthy volunteers electively dehydrated, they nail it, basically. They can perfectly rehydrate themselves as judged by any of the ways that we would look at dehydration. So they put their weight back to normal, they put their osmols back to normal, they put the urinary variables back to normal, and they say, I don't feel thirsty anymore. And they don't seem to overhydrate themselves. Now, I'll show you some of the data on that. Here's the conclusion from the study. Randomized crossover trial, assessing whether you could correct your own thirst. A system delivering IV fluid in response to subjective thirst was better than the conventional method. That's the trial design. Crossover. So get the diuretics and then either randomised to us being clever about your hydration, or the individual saying, I'll hit the button until I don't feel thirsty anymore. And if you let them hit the button, they more rapidly rehydrate. So they take their thirst score back down to 0 more quickly, but they also correct their weight, correct their osmols, correct everything. Now, lots of caveats with that. This is a long journey, because will that be the same with frail elderly patients who've had morphine in the PACU? Can they reliably do it? Don't know. So lots of work ongoing to determine if this might be part of the future. However, start to look a little bit more closely at your patients and ask them, do you feel thirsty? Yes. And then go and look at their electrolyte panel and do the quick calculation. More often than not, they're hyperosmolar. And if you give them a little bit more free water, they'll tell you they feel less thirsty. This is anecdotes now. They tell you they feel less thirsty. And they seem to pee a bit more as well. Because the problem with that top right-hand panel is if you're hypervolemic and hyperosmolar, which is usually mildly hypernatremic, you don't want to pee. So you're in a very bad place. You're oliguric and fluid overloaded. And what do we traditionally treat that with? More salt and water. That's how we traditionally treat that. So I'm thirsty, I'm drowning in seawater, help me doctor, here, have some more seawater. Okay, so not a good setup. There's the individual patients in that, and it all looks as though the green lines are the ones when you self-hydrate. That's the thirst score against time. Please have a look at the paper. It might be part of the future, or we might still be talking about why it never worked in 20 years' time. But hey-ho. Talking about something we've been talking about for more than 20 years, hemodynamic management perioperatively, or goal-directed therapy, or goal-directed fluid therapy, or goal-directed hemodynamic therapy. I've been, like many of you in the rooms, involved in numerous different groups producing guidelines on this complex subject. And when you get everyone in the room, even the most skeptic people, the naysayers, when they hang out together for a couple of days, they usually reach the same conclusion, which is that there is a place for more advanced hemodynamic monitoring in higher risk patients who are more likely to have big fluid shifts, bleeding, etc., etc. So this is an example that comes from the Perioperative Quality Initiative, relatively recently formed. It's produced a whole series of guidelines. This is about fluid management in the context of colorectal surgery and enhanced recovery pathway. So the top left-hand corner is probably the most important diagram. It's adapted from Miller, Roach and Mythen, a paper Tim over here wrote, talking about a risk-adapted matrix, which is probably what we all do in our head when we're saying how we're going to set a patient up. You know, what level of, how big an IV am I going to have through to central line, arterial line levels of monitoring. We look at the risk-adapted matrix, we look at the patient risk, the procedural risks, and we construct this little matrix. So the sickest patients having the biggest surgeries get all the bells and whistles. The majority of patients, who are the patients having minor intermediary surgery, get basic monitoring. And if you look at the middle panel, so I go to the right-hand side, it's a bit small for you to read here, but that's the context of a whole enhanced recovery pathway. It says there's more to it than just what goes on in the operating room, the theatre. There's the carbohydrate drink, there's the avoiding bowel prep unless it's necessary, there's the risk adjustment, there's the modifying your monitoring and environment, then there's the goal of getting the IV down as quickly as possible, and then drink, eat, analgesia, move, sleep, go home, enhanced recovery. So the middle one is probably the important panel. In the journey from still not quite knowing exactly the answer to the goal-directed therapy thing, many of us forgot to mention that you're supposed to use your brain in all of this. So the one in the middle, which has a treatment pattern, says, one, is there a clinical problem? I.e., if these numbers are abnormal, look around and say to yourself, I wonder what's causing this problem. And lo and behold, if they're 1 litre positive and they're head down tilt, having laparoscopic surgery, and you can see there's no bleeding, and the stroke volume goes down, if you're measuring it, it's probably not hypovolemia. Anyone disagree with that? Yeah, some people still think stroke volume went down. Algorithm said, give volume. Okay? So it says, is there a problem? What do you think is causing it? Use your monitoring, use your brain. And then once you've used your brain, we all know this, fluid is not always the answer. It's often the answer, which is why we've been banging on about it for a long time, but it's not always the answer. So it's fluid and or monitoring afterload, vasoconstriction, vasodilatation, or the need for increased contractility. So here's, as far as I know, the latest trial in this space. the effect of goal-directed hemodynamic therapy, very important, hemodynamic therapy, on post-operative complications in low to moderate risk surgical patients, a multi-center randomized trial, the fedora trial. So it's about 420 patient multi-center RCT out of Spain. It's about 6 centers, mainly around Madrid. The technology is important in discussion. This is a Deltec-sponsored session. Was the esophageal Doppler. And when I show you the results, one of the ongoing debates about the esophageal Doppler compared to other monitoring technologies, and I consult for other companies, and I think all the technologies have plenty to offer, is the Doppler is undoubtedly, everyone agrees, the most precise. It's actually the only true direct measure of flow because it measures velocity in the descending aorta. Almost everything else is a surrogate measure which has greater utility, but everyone agrees is less precise. So the challenge in this always is offsetting precision with user-friendliness, and that's a debate for another day. Anyway, this is a Doppler trial. And the conclusions, in 420-patient multi-center trial, are pretty dull, really. Hemodynamic optimization reduced complications, hospital length of stay, in low to moderate risk patients having major abdominal surgery with no effect on mortality. Goal-directed hemodynamic therapy can be beneficial even in low to moderate risk patients. Why do I say that's a bit dull? 420-patient multi-center study. This study was stopped early, well, that's one thing, because of the use of hydroxyethyl starch as the colloid of choice in it. So ignore that for 1 second. It was still adequately powered for the primary outcome variable. It's only published in the BJA, nothing against the BJA. I'm on the editorial board. And not in JAMA, because it tells us exactly the same as the meta-analyses have been telling us for 20 years. So it's another trial that tells us exactly the same as the meta-analyses have told us when done repeatedly. And some people say, just give it up, will you? We know that. He said, well, we might know that, but most people aren't doing it. So if you look at the METS trial recently published, which has within it the level of monitoring for the patients, if I'm reading it correctly, 1,400 patients, the METS trial, they show the level of monitoring within it. They're pretty high-risk surgical patients, high complication rates. 50% get an A-line. 22%, I'm sorry if I'm just slightly off on the numbers because it's not my paper, 22% get a CVP line, which we've all concluded is useless, and about 8% get cardiac output monitoring. So that's how convinced we all are about this. It's higher numbers, it seems, in the UK, which you may hear more about later. But anyway, how's this world moved on a little bit? Well, I've been one of the people who's been obsessed for a long time about the fluid management side of it, so goal-directed fluid management. The idea that you give boluses of fluid only enough to get what you think is an optimal stroke volume. And some people do that by, in a patient who's getting positive pressure ventilation, by looking at suppression of stroke volume variation or pulse pressure variation, for example, or doing it this way, with an esophageal Doppler, giving fluid boluses to maximize stroke volume. But that's the goal-directed fluid therapy bit of it. It's the giving what you hope is just enough and not giving too much. And that Goldilocks idea, for a while, because people worried about patients getting too much fluid, interesting reflecting on the results of relief earlier on today, had started to be called goal-directed fluid restriction, i.e., I'm not going to give too little, which we know is bad. I'm not going to give too much, which we know is bad. I'm going to try and give just the right amount. Now, I said, twist in the story, potentially, blood pressure. So, we know flow is important. Flow is very important. And having blood supply to every organ in the body is very important. But pressure is also important. So you have to have a minimal opening pressure to maintain constant capillary flow. We all know that. Your brain cares quite a lot about it. Your heart cares quite a lot about it. Your kidneys care quite a lot about it. This is data out of the Cleveland Clinic looking at the cumulative effect of periods of hypotension perioperatively. It's observational data, large cohorts. And this is where this sort of 65 messages come from. Whether you have 1, 3, 5 or 10 minutes of hypotension perioperatively in major non-cardiac surgery, you get a cumulative increased risk of having myocardial injury, judged by the troponitis called MINS, and or a major cardiac event, or an acute kidney injury. So people, as a result of that, have looked at all the available data, this is not all of it, and said, yeah, what you should worry about the blood pressure as well. So that's just cause and effect relationship. What about intervention? Well, we've had, as far as I know, only one relatively small interventional trial in this space so far. It comes from Emmanuel Foutier and colleagues, so it's a French trial, it's multi-centre, and it's looking at the effect of individualised versus standard blood pressure measurement. Now, if you haven't read this study and you are thinking about changing your practice, please do read the whole paper, because the superficial version of it is give somebody some vasopressors, keep their blood pressure up, they do better. It's much more complicated than that. So the first thing is the target blood pressure was informed by ambulatory blood pressure, that recorded prior to the day of surgery. They then used in the interventional group the systolic, not the mean, blood pressure from that group, and gave a peripheral infusion of norepinephrine to maintain blood pressure within 10% of the preoperatively recorded value. Everyone with me? So I was 120, take 12 off that, I've got a new target. Norepinephrine infusion, if I'm dipping below that, turn the norepinephrine up. Important variables. Norepinephrine infusion, okay, given peripherally, interesting, 2.5 milligrams and 250 mils through a dedicated peripheral IV line. Best guess dose started, then adjusted according to preoperative blood pressure. The blood pressure separates in a possibly meaningful way. There isn't actually a very big difference between the blood pressures in the two groups, but their primary outcome variable, in this situation here, the standard treatment is the good news. The higher line here is the good one, in this particular plot. The outcome they conclude is statistically significantly better. So the p-value is 0.002, so people's eyes are immediately drawn to that. It's below the magic 0.05, so it must be true. Therefore, we should do it. It's published in JAMA, so it really has to be true. Look down at the numbers at the bottom. It's a relatively small trial. It's under 300 patients. So I think people are intrigued by this, but it's not necessarily definitive by any means, but they're intrigued by it. Now, very important, if you are going to think about modifying or tweaking your practice this way, is back to this volume then squeeze issue. Because in the appendix, it's crystal clear that one, because it's allegedly a standard in France, there may be some people here who can counter that, national documents published, that cardiac output monitoring is recommended for these higher risk patients, that all the patients had cardiac output monitoring, don't know what with, I don't know what with, then they all had fluid boluses, which ended up being a hydroxyethyl starch fluid bolus to maximise their stroke volume, and then they were randomised to a norepinephrine infusion or not. So the point I'm trying to make there, I'm not saying it's right or it's wrong, is it was fill then squeeze, not just squeeze. And the thing I'm worried about is people going back to just squeezing the whole time. In other words, the inappropriate use of vasoactive agents to over-constrict somebody who is relatively hypovolemic. So that's a potential unintended consequence of this, but that's intriguing. So back to the fedora trial. We used to think this is a big trial. Now we think this is a small trial. Got to get into the thousands to be called a big trial now. So this is a small trial, multi-centre, randomised controlled trial. Interesting because it's not just fluid management. Very similar to that trial I just showed you, the INPRESS trial. By default, it used a haemodynamic framework that was very similar to that recommended by the POCI guidelines. So it said, in the interventional group, get your Doppler down, measure your stroke volume, cardiac index, look at the mean arterial pressure. For those of us who practice this way, it's very familiar territory. Give your 250 ml bolus. And for those people doing it with, Paul was saying earlier, with pulse pressure variation, it's the same mindset. In other words, look, is there an evidence of preload responsiveness? But here, it's optimize your stroke volume by the Doppler. Once you've done that, say, is the map okay or not? If the mean arterial pressure's okay and the cardiac index is inadequate, do something about the heart. If the cardiac index is okay and the map is low, give a bit of squeeze. And in this trial, about a quarter of the patients got a bit of extra squeeze. Very few patients got the extra inotrope. But it's not just goal-directed fluid management, it's goal-directed hemodynamic management, which for those people who are very into this are kind of looking quizzically as if to say, I just do all my cases like that. What are you talking about, old man? Give it up. A few other interesting points. I say this is nothing against the trial, fantastic trial, but relatively small still. Optimised 2 will be a couple of thousand patients. Flow early, you'll hear about later, is many thousands of patients. If anything, the benefit was possibly greater in the patients having laparoscopic than open surgery. That's been one of the big debates. My theory on that is because it's haemodynamic management, not just fluid management. So in laparoscopic surgery, if your heart doesn't work very well, your head down tilt, you get pneumoperitoneum, you're at risk of heart failure, not hypovolemia. I did work on that 20 plus years ago at Charing Cross demonstrating that. Those of us who monitor those cases know that. The other thing is the recurring theme, again I apologise for the size here, of the fact that AKI and infectious complications, pneumonias, etc., are the ones that seem to be affected. So big picture stuff, in all these active trials, those seem to be the important outcome variables. And MINS, myocardial infarction, however you choose to summarise it, is less than 1%. So big trials going after myocardial infarction, it would appear in Europe, doesn't seem to be a very sensible primary outcome variable. The leader seems to be either AKI or these infectious complications, and once again it's the deep-seated infections, wound infections, that seem to be the recurring theme, very much like relief. So, conclusion I've shown you, it looks like it probably works in patients having major abdominal surgery and can be beneficial even in low to moderate risk patients. That's the editor's key points. So to conclude, now this one's been put to bed, we hope, along with the saline versus balanced question, which we put up as a poll because there's been 2 papers published in the New England Journal of Medicine this year totaling about 27,000 patients that suggest that the use of saline produces worse outcome, including major morbidity and renal injury. We put a poll up, and apparently a third of the people who voted in the room so far still think it's a live question. So trialists, give up now. So why not just restrict? And I was on our surgical intensive care unit last week. Professor Miles is visiting on sabbatical here. I think we've made you do at least 2 grand rounds so far, have we, Paul? There were patients being brought back to our intensive care unit dry as a crisp. Dry as a crisp. And why? Because the short-term fuzzy feeling for running someone dry, which is why some people have wanted to do it for years, is that the patients look great in recovery. You can whip that tube out, they breathe well, and they go home quickly. So that gives you a warm, fuzzy feeling. This is observational data before the relief trial. I'll come back to relief in a second. From a single centre in North America, published in March 2017. It's from the Mass General Hospital. They've looked at their registry of just over 92,000 patients, and they've broken the perioperative fluid levels out into quintiles. So as you look at it, top left-hand corner, Q1 is the driest patients, Q5 is the wettest patients. It looks like that Bellamy curve exists in observational data. Look a little bit more closely. 30-day mortality is indeed statistically significantly higher in the wet group. But it's also a hint that it might be sneaking up in the driest group. This is the warm, fuzzy feeling. Pulmonary complications are undoubtedly more common in the wet group. And they look as though they're possibly the lowest in the driest group. Post-operative length of stay, get them out of hospital quickly, they can breathe well, get them out in 2 or 3 days, enhanced recovery, zippity-doo, off you go, looking better. But hang on a second, why are the costs highest in the driest group? Because, as we've heard from relief, the silent killer of acute kidney injury is more common in the driest patients. One of the potential unintended consequences we worried about in the UK after the induction of enhanced recovery was the possible perfect storm that had been shared unintentionally of people saying, don't give people too much fluid, that became somehow restrict the patients. Give them multimodal analgesia, which became, you've now restricted your patient, you're going to give them non-steroidals round the clock. You've got a patient with pre-existing elevated creatinine who's dry as a crisp, you're giving them non-steroidals round the clock. Oh, and don't forget to restart the ACE and ARBs, just to put the boot in. Okay? So anecdotally, we ended up seeing patients admitted to critical care for hemofiltration in some places where they had never seen it in their life on an intensive care unit. And nationally, there was a blip in post-surgical acute kidney injury. So just beware of unintended consequences. I don't know what caused it, but that's real. So to reflect on relief, fantastic trial. Surely that's definitive now. But already people are saying, oh, I don't believe this, I don't believe that, I don't believe... No, come on. We at least know the answer to a few things now, and that's on the list. 3,000 patients. And as Paul alluded to, this study is performed on a relative minority of what appears to be common practice in certainly the United States of America, where we have more of the observational data. I've showed this to many of you before. This paper, very bravely published by UC Irvine and Vanderbilt in the USA, looking at around 6,000 patients, trying to determine what determines how much fluid you get perioperatively in major non-cardiac surgery. Is it duration, blood loss, CVP, heart rate, urine output, all those usual things? No, what is it? You all know. It's the anaesthesia provider. And not only is it the anaesthesia provider, it's with huge variation. So in an applied example, the author showed that a patient weighing 75 kilograms undergoing a 4-hour procedure with minimal blood loss could receive anywhere between 700 mils and 5.4 litres of crystalloid for exactly the same procedure. Now that is shocking. That's not 2.1 versus 3.1 litres. That's not zero balance compared to up 2 kilos. That's 700 mils to 5.4 litres for the same case. Julie Thacker is at the meeting, who's a surgeon from Duke you'll be hearing from later on. I was part of a group that worked with her to look at how much fluid you can expect to receive for elective colon surgery at 499 hospitals in the USA. And remember, Paul said the new rule is 3 plus 3. So this is for the whole hospital stay. So that would be 6, which is in there somewhere. So 499 hospitals, similar types of surgery, 84,000 cases, 10% of hospitals will give you 10 litres. Oh, everyone's going, no, it never happens anywhere near me. Shocking. It only happens in America and those other places. Some places give you 1 to 3 for exactly the same procedure. Some give you 21 to 23. They have an IV running for a week. Now, we say that's shocking, but this is reported on a regular basis in quality journals. So, evidence-based. If you get asked the question, how much should you give a patient having a colectomy? If you gave the answer, well, anywhere between 700 mils and 5.4 litres intraoperatively, and anywhere between 1 and 23 litres postoperatively, that exam answer has to be marked correct, because that is an evidence-based answer based on current practice in the United States of America, and often when we look elsewhere. So if we put that in context, does that really matter? It's just a few extra litres of saline. I'm sorry to show this chestnut. We show every single time from Andy Shaw and John Callum. Actually, the original ones came from one of our colleagues in the UK, but they're different potato chips, so these are more international. A litre of saline, 0.9%, contains 9 grams of salt. So that's 2 days of salt per litre of saline. That's the potato chip equivalent of 25 bags of this particular type of potato chip of salt per litre of saline. So even when you land your patient in the new sweet spot, they do have 4 days of extra salt that they need to handle. That's good to be landed in that place, it would appear. But you've got to be careful what you do next, because that's a lot of extra salt still to handle. So let's look back to the Goldilocks curve, the Bellamy curve, the U-shaped relationship. We know too little is bad. We know too much is bad. We know we're looking for the sweet spot. Again, this is observational data from Julie Thacker and colleagues, looking at over 600,000 cases, dividing the fluid into quartiles perioperatively. Looking here, for example, at just over 500,000 hips and knees, just over 80,000 colons. That's the sweet spot. That's 50% of the patients. And guess what the number is, Paul? It's 3. So observational data, the middle of the sweet spot observationally is 3 litres. I won't say that's right or wrong, but when we compare the patients in the 3 litre space to the patients, the 25% who got more than 5 litres, or the 25% who got less than 1.7 litres, the outcome is worse in the 2 extreme groups. Now, the important point there is when you put that together, that's the outcome. You compare the sweet spot to the liberal and the restrictive. Paul's trial, the relief trial, is within that box in the middle. So both of the groups they've compared are within the 50% observationally that are between around the 3 litres, that are between the 1.7 and the 5. The point he was making, he's already eliminated the 25% at the high end that still seems to go on, and the 25% at the low end. So the very least we can go back next week is at least to get people into that box. Even if you're going to debate where you're 0 and the slightly moist, I hope you'll go back and say our target is now to be a little bit more moist. Personally, I'd hope you go back and say I want to do it in a goal-directed way. But let's stop the carnage in the 50% of patients when we observe this. Same for ileus, by the way. Those who like to run patients dry to stop them getting ileus, it actually is a higher incidence of ileus if you're restricted. So how do I put those three papers together? Well, the world's changing the whole time. It's great. New big trials coming along. Optimise 2 is coming. Floella is coming. I think there are other big trials going on around the world. There are quality initiative endeavours. The Foutier trial, top left, I think we all agree we should continue to take blood pressure seriously, but probably should pay it a little bit more attention than maybe some of us have been doing for a few years. And I think there'll be a growing interest in whether or not one can safely use peripheral norepinephrine infusions in patients who are at greater risk to keep that blood pressure up. And I think there's large trials need to be done to try and determine the safety-risk balance there. Fedora, I just think reinforces what we've known from the meta-analysis forever. Not forever, for the last 20 years, forever in EBPOM anyway. And Optimise 2 may or may not give us a definitive answer to that. Optimise 2 has a different algorithm, it has a different technology, it has different interventions, it has different endpoints. It's a very good, important, large trial, but it's not exactly the same. And then there's Relief, and I'd say hopefully with Relief you at least know that running patients on the drier side, which would include zero balance, is probably not in their best interest. And that rule of 3 is a great start. Why do I think the question is still alive? This is a little bit naughty, because it's naughty. This is putting on a single graph the AKI rates from Relief and the AKI rates from the Fedora trial, which is the goal-directed hemodynamic therapy trial. So when you look on this side, you've got the restrictive group from Relief and you've got the control group from Fedora. Remarkably similar rates of acute kidney injury of about 8.5%. If you then look to the other side, you've got the moderately liberal group from Relief, and the AKI rates are down to 5%. If you look at the goal-directed one, the AKI rates are down under 2%. And when you look at the meta-analysis of the active hemodynamic trials, they're closer to that 1 to 2% than they are to the 5%. It's a little bit naughty, as I said, it's very naughty, because you shouldn't really be comparing trials in this way, but that's why I think this question, as we all do, remains alive, because it may be that the more proactive management of hemodynamics produces even better results than careful, meticulous fluid management, which would appear to be rare in its own right, and choosing to be moderately liberal compared to restrictive. I'd hoped that the saline versus lactated ringers question was over, but a third of you who voted thinks that it's still alive. Those are the 4 fluid stages of life. It shows a milk bottle, a Coke bottle, a bottle of famous North American beer, and a litre of saline, the 4 fluid stages of life. If the 2 in the middle don't get you, a resident will get you with the one on the right-hand side at the end. After this, we're going to do the colloid-crystalloid debate. That's a slide I stole from good friend John Myberg. You all familiar with that one? Position A, position B. Is everyone familiar with that? So I got married. It used to be hung. Those of you listening at home, there's a loo roll hanging with the paper hanging down the back close to the wall or the paper hanging over the front. Okay. Now, I was brought up on the wrong side of the tracks, it would appear. My mum used to hang it in position A. Okay. Whew, that's shocking for some people. My new darling wife comes in and sees it that way, gives a loud scream and says, "You can't let anyone see the loo paper hanging that way around. You've got to hang it in position B, because that's probably what the Queen does." Trust me, it's what you do with it that matters, okay? That it's all about dose and application, and that's the colloid-crystalloid debate that we will torture after the break. Thank you for listening. Some screenshots there for some various websites that contain some of that information. As I said, the Top Med Talk podcasts are there, including lots of great discussions about Relief and other subjects. If you go into the search engine and you put in Relief, for example, you get about 3 interviews with Paul. If you put in Balanced, you'll get Andy Shaw about the colloid-crystalloid studies. In a second, I'll put Slido back up. That's the end of the talking bit. Thank you.
And don't forget you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. ebpom.org. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September. ebpom.org for more details. That's ebpom.org.